Good morning, doctors. This is Luis Carrière from Barcelona, giving this live webinar from, and now we are today in Philadelphia in the USA. And welcome to everybody. Welcome from people from every part of the world. Today we are 1,000 people. So thank you. Thank you for joining us. Thank you for joining us in this live webinar. We are going to talk about how can we approach the malocclusions, how can we solve the complexities in orthodontics, and how can we enhance our efficiency in the orthodontic treatment. And we are going to talk about class 2, we are going to talk about class 3, and a little bit about class 1, which is also a very interesting approach in which we can really enhance the efficiency of our treatments also in those cases of class 1. Orthodontics is all about face. We are at the end sculptors of the face of the patient. We are sculptors of the harmony and the beauty of the profile of the patient, and we are the only professionals out there that are able to move the hard tissues of the patient according to the beautiful exhibition of a nice relation between the nose, upper lip, lower lip, and chin. So according to that, we need to be experts on which is the golden proportion of the face. And one of the most interesting points is this brought by Leonardo da Vinci, who took the studies of Vitruvius. And he came out with a beautiful distribution of the 3/3 of the face, establishing that all of them should be proportional. And also, we were able to split the lower third of the face also in 3 totally proportional lower thirds. This was giving us the golden proportion of this face. No? So the question is, can we accomplish a nice relation on this lower third of the face that is balanced, proportion, and adequate? And of course, the answer is yes, we can do it. And we will see how can we do this. We are going to talk about how to solve the sagittal problems using the motion appliance. This appliance that is going to give us the possibility of moving the posterior segments in a block into class 1, of accomplishing class 1 occlusion of the canines, premolars, and molars, and at the same time rotating the molars, but avoiding any kind of over-rotation just by the self-engineered collision points established on the design of the molars. Simultaneously, we will be able to upright those molars that are excessively measured inclined, we will be also able to upright. So we will be able to rotate them and upright them, but also self-engineered collision points established on the design of the joint appliance will help us into limiting any possibility of having distal tipping of the molar during the correction. So we want uprighting, but we don't want distal tipping. So we can accomplish that just by establishing a nice and efficient design on the headboard of the posterior segment of this appliance. So the objective will be to accomplish a super class 1 occlusion in class 1 of the posterior segments, that it will be canines, premolars, and molars. Nice rotation to the distal according to the beautiful study that Dr. Stoller gave us in 1954 at the American Journal of Orthodontics, establishing which is the importance of the beauty, of the adequate occlusion of the molars for establishing a solid and consistent occlusion for the future. What we need is a stability of what we accomplish. Okay? So this is an appliance. It's like a long bracket that is positioned on the canine, is positioned on the molar. When the canine is so high or is blocked out or is in the palatal, then what we use is a shorty, which is the same appliance that goes from the molar to the fresh bicuspid. And the objective is to accomplish this movement in a block of teeth. Instead of moving single teeth, we will move posterior blocks of teeth into class 1. Okay? Now, let's start with the cases. Let's start with these cases of mixed dentition, phase 1. The normal age of these treatments normally are late 6-7 years old, in which the patient is having 4 upper permanent teeth erupted, the front ones, the incisors, and the lower front incisors as well, and still need to change 12 teeth, which are temporary canines and temporary molars. So a patient like this that is having a massive protrusion, a very important protrusion of the mandible, we want to establish a correct relation of this one. How can we accomplish that? No? How can we bring this patient in phase one and inviting this patient to establish a correct, balanced, and adequate relation between the nose, lip, and chin? Well, the patient establishes this scenario in which she is having a class 2, but she's having this mixed dentition, no? Upper 6 is erupted, temporary canines in place. This is a good moment because when at this age, at late 6, 7 years old, the permanent dentition on the canines and bicuspids are going to be quiet for a couple of 3 years, in between 2 and 3 years. So we are going to be easily have a good moment of silence in terms of changing. Then we're going to place the motion appliance on the 6, and the motion appliance is going to be bonded on the temporary canine. The objective will be to bring the posterior segment in class 1. Once we have this posterior segment in class 1, we are not going to stop here. We are going to go for overcorrection. You say, why do you overcorrect in mixed dentition? Well, if we look at occlusal surfaces of the temporary teeth, we will see that those temporary teeth have flat occlusal surfaces. So there is a lot of instability of the occlusion of mixed dentition. So we need to overcorrect because this instability is not locking in a supermatching interscrustation of as we would have in a permanent dentition. So what we pretend then is to overcorrect. This canine will be overcorrected according to the distal reach of the lower canine or the nasal reach of the first lower molar, a little bit as like a quarter or half a cusp of this molar of overcorrection. We are good with that because now we can release the appliance and leave the case to evolve spontaneously. Nothing. We are not going to place anything. We are just going to release this case just to change, to make the change of the permanent dentition. So we go from stage 1 to the overcorrection, but here we can see that the patient is having a complete different scenario of the position of the mouth. So this functional element, this functional position that we established and we invite this mandible to position properly is going to help us very much into the accomplishment of a good mandibular position. And the question comes, here we have a patient. I like sometimes to place movies of patients in which we are able to see the beauty of the position of this mandible, the natural, the patient in motion, the patient in action, in which we can see how the patient looks. No? But here is the evolution of this case. No? Those temporary teeth that they moved into a more distal position, this mandible that has been invited to be projected more forward, now will establish a solid condition because we established an overcorrection, and the patient now barely needs a second phase of treatment. This patient probably will not be necessary to do a second phase of treatment, but look at the change of profile from the beginning to the end of phase 1, and from the end of phase 1 to the beginning of phase 2, which at this point, this particular case, is completely unnecessary because it has a good occlusion. This one has no sense. No? This is another patient, typical patient of the same age. This protrusion of these mandibles that we need to interfere, and we need to jump and generate the scenario of a normal development of this mandible. No? So in this patient that is having the same scenario, 12 teeth to change, we are going to place the motion appliance, going to be on the molar, on the temporal canine. We are going to protect the lower arch with a vacuum invisible retainer that is going to keep everything in place for the use of the elastics. So its lower arch is going to be protected. Now we can use the elastics and accomplish a class 1. Now, it's a class 1 and overcorrected class 1. Another thing that we can do if there is some spaces in the incisors is to just align those incisors with a round wire, close the spaces roughly, because remember this is a phase 1 treatment and this patient will need probably this too. So we don't need to change wires here. You use a round wire, the 2x4 brackets, and round wire is more than enough. And then we release it. We leave the case. But we leave the case in a dentally speaking scenario in which the patient is having a beautiful one, a correct overjet of the case. So the mandible here we can see that the patient is having a beautiful mandible now, a beautiful, complete different relation of the structure, right? So this treatment can be beautifully enhanced by a functional approach with the Carriere motion appliance, right? In class 2 malocclusion. So here we are, the patient, I think it's 7 years after the phase one, no? Appears in the office and is coming, well, with this scenario, she's coming with this piercing, but, well, she has a scenario in which the patient rejects any kind of second phase treatment. She says, oh, I don't want any treatment. Well, what we see? Well, treatment that is quite acceptable. We need a little bit more of class one, of course. In this case, I would place a motion appliance, but the patient does not want treatment. Well, it's not that a problem, because now she's having a beautiful relation between the nose, upper lip, lower lip, and chin, and she's beautiful. Then let's change to another type of patient, a patient on which the age is around 14 years old, those adolescent patients in which they have not had any kind of phase one treatment, and we find that the patient is having a massive erosion. Many times, those patients are prescribed with surgery. And these patients, one of the things that they have in common is the wrong position of the mandible, especially at the temporomandibular joint area. Not only those mandibles, on those retrusive cases, the class 2 malocclusion and this mandible protrusion is generating a wrong position of the structures at the temporomandibular relation. So the condyle normally is back and up, and this is shifting and compressing the posterior ligament of the disc, shifting the disc forward and contracting the upper head of the lateral pterygoidus muscle. So this is not good, because sometimes can give symptomatology, temporomandibular disorders like bleeding or pain, other times not, but this can be something that can be not interesting. Here we can see a patient that probably is having around 14 millimeters of overjet. It's a patient that is a great overjet, massive intrusion of the mandible. And the question is, can you solve this with the motion appliance? And I would say not only solve this with the motion appliance, of course we can solve it, but also establish a good relation at the temporomandibular joint level and establish a natural and correct relation in between the mandible and the maxilla. This is the most important thing. The motion appliance is going to help us into establishing a good position, a good relation between those structures. Let's see. What we are going to pretend is to go and accomplish this canine relation. The cusp of the upper canine has to fit perfectly in between the lower canine and the back cusp. So we will bring the posterior segment into relation and establish a correct mandible position. Okay? Let's start. Let's place this motion appliance. We place the motion appliance on the uppers. We protect the lower arch with a vacuum invisible retainer. Vacuum invisible retainer that you cannot see it here, because this is a patient that is a same-day start. Same-day start means that it's a patient that is coming for the first appointment, first time visit, and on the same day the patient is coming, we start the treatment. So we do the records, we do all the necessary exams, and at the same time, on the same day, we place the motion appliance, we place molar tubes, and on the next day, we're going to send the patient the vacuum invisible retainer to home, right? Or with UPS or whatever, any courier. So after 2 months of treatment, you are seeing that this posterior segment is in the half correction. This caused super full class 2 malocclusion, now is in the middle. And after 4 months, we accomplish a class 1. Now we can see that in this particular case, there has been a certain extrusion of the cranium. Well, this is not concerning to us, because this is canting the occlusal plane and helping us into establishing a better relation of the mandible and the maxilla. This is very interesting, because here, this 14 millimeter overjet has been massively decreased. And this interestingly approach in which we have been able to decrease this overjet will help us very much in establishing a better position of the mandible, because now the mandible is establishing a nicer relation. Here we have the patient that has not been already treated of the incisors, but we can see that this mandible is establishing a completely different scenario than the patient had at the beginning of the treatment. So this is our objective, to bring this relation into the natural position. But the most important thing, why can we accomplish this change? Because look at the condyle. The condyle is at the back and up. So we invite this condyle to be distracted from the deepest part of the fossa, and we release the space for the disc to be self-positioned, spontaneously positioned, where naturally it has to fit. Because it's very important to establish a good relation on those particular patients. And this is the most important. Now, once we have this scenario, after 4 months of the approach of the motion, now we are ready to switch into an easy case to solve, because now the case is in class 1. This complexity of this case has completely been released. Now this is It's not anymore as a complex case. What we are going to do is we place the Carriere SLX brackets, we place a wire, we close the spaces in between those four anteriors that we generated by the position of posterior segments. Once those spaces have been closed, we place a figured metallic ligature in between the four anteriors, and now we have a perfectly unit of the anteriors. And now what we have to do with those anteriors? Just bring them back with a rectangular wire and 90 with a power chain that will go from the second bicuspid to the first bicuspid, and bypassing the canine will go to the hook, that is crimpable hook that is placed on the wire. This crimpable hook obviously has to be a little bit distal to the lateral incisor, because we need wire to slide back this wire and retract the anteriors beautifully, right? This is what we like, that we see in the movie, retracting the anteriors. Let's see. This is what we like, retracting those anteriors with the power chain and sliding back the wire. This is what we pretend. So why we don't place the power chain on the upper molar? Because the upper molar has been rotated beautifully, distal with the motion appliance, and we don't want to rotate initially the molars, because if we rotate initially the molars, what we're going to do is to disocclude the tricuspids and canines into class 2. So that now, once we accomplish class 1 with the motion, what we pretend is to keep this molar intact. We don't want to move this molar with any input initial, because this would ruin our approach. Okay, so here as we are, we retract those anteriors and we finish this. This particular case was 4 months and 13 months of SLX brackets. And the beautiful patient. Now the patient has a nice relation between the mandible, the maxilla, the nose is balanced, the upper lip is nice, the girl is with a good condition, and the airway of the patient also is beautifully exhibited, which is also very interesting and very. So in 17 months of the treatment time, we can go from a scenario that is really concerning into with a simple approach, predictable approach, which is very interesting. A minimally invasive approach, which is also very interesting, balance the position of the mandible, balance the structures of the patient, and establish a beautiful girl, a nice-looking girl, a girl that is now satisfied, self-confident, and in good condition. And the question comes, okay, very interesting. This was a class 2 division 1, but what about class 2 division 2? Those cases that have deep bite, retroinclination of the incisors, mandible is blocked back, the patient is retrusive. What can we do here? Well, this is the typical scenario of a complex class 2, division 2, with retrusion of the incisors, super deep bite, blocked mandible back. Those patients normally they have a lot of temporal disorders, because the mandible is completely blocked. No? The approach will be exactly the same. The technique is the sagittal first. They remove the sagittal problem at the beginning of the treatment. Dr. Engel classified orthodontics in class 1, class 2, and class 3 malocclusion. Why is that? Because the major problem that we have with orthodontics is the sagittal condition of the patient. So here we have an approach in which we are able to accomplish a beautiful relation of the sagittal problem, completely remove the sagittal problem at the beginning of the treatment, and from that standpoint, be able to convert this case into a simple case. So that is what we are going to do. We protect the lower arch with a vacuum invisible retainer. We place a lower molar tube. If we have a lower 6, we use a lower 6. If we have a lower 7, we use the lower 7. We use the elastic protocol. Elastic protocol, we have 2 types of elastics: 6 ounces 1/4 and 8 ounces 3/16 inches. We start with 6 ounces 1/4, changing every time, every meal. So every 8 hours, new elastics, and full-time elastics, 24 hours a day. Except for meals. Then after the second month, we switch into force 2, which is 8 ounces 3/16, changing elastics every 8 hours. So this is going to be a rocket, and we immediately accomplish a class 1 occlusion. But here we are not yet there. So we go a little bit more on, and you can say, oh, look, this has been a little bit extruded. It has been extruded, the canine in this particular case. Yes, because it was a class 2 division 2, was a complex case. But it's not a problem, this, because now when we switch into brackets, now when we accomplish class 1 and we're switching to the brackets, the canine is immediately repositioned into the correct height. And now we are able to initially level the anteriors, close the spaces in between the anteriors, maintain those anteriors with a figurate metal ligature, and now retract it in torque an intrusion of those anteriors with a beautiful exhibition of the nice retraction with the passive self-lighting bracket that is the Carriere SLX 3D bracket. Okay, this was the Carriere SLX bracket. Well, here is the case finished. A case that was complex, a case that started with a massive pressure division tool. She has a beautiful smile. She has a nice relation between the nose, upper lip, lower lip, and chin. The mandible now is exhibiting a better relation, and the patient looks much nicer, which a nice relation between the structures. Here we can see the X-ray of T1 starting at the end of the motion, in the middle, and at the end of the treatment at the end. So you see that those incisors are self-uprighting and self-diminishing the torque with this. What about those cases? No, patient that is retrusive, patient that has a disruption, an incorrect golden proportion of the lower third of the face. Remember that we were talking about the proportions, the golden proportions established by Leonardo da Vinci. These proportions that were so important in order to have a beautiful relation. No, we need that this patient that is starting the treatment, we need to end up with a good relation between this upper third of the lower third of the face that goes from the subnasally to the stomach, which is the line between the lips, and the two lower thirds of the lower third of the face that goes from the stomach to the neck, right? So can we change this only with orthodontics, or we really need the battery? Battery is low. So, or we really need this. Put it 1 second that battery is low here. We got loaded, and let's go. So what we're going to do is to place let me see 1 second. Close. It doesn't matter. What we are going to do is to place the motion appliance. Place the motion appliance and accomplish a class 1. In 5 months, in this particular case, we accomplish a class 1. You say, in a patient of these years, and a patient of this age, 5 months to me is too much. So this means that this patient probably in the first 7 months was not really too much collaborative. So we need to identify that and say to the patient, hey patient, you need to cooperate because this appliance needs cooperation. So it's very interesting that patients like those normally will run out of the problem very easily with a very simple relation. Okay, so we finish the case, and we finish the case in a total treatment time of 17 months. But the most important thing is that this patient now has a beautiful relation between the lower third of the lower third of the face. This golden proportion. This golden proportion that is so important and so interesting. This golden proportion that Leonardo da Vinci has given us. How have we done this? How can we accomplish that? Well, easy. What we do is to generate the scenario. To generate the scenario of a correct relation of the upper teeth. I mean that we never extract two upper teeth on this upper in this two upper bicuspids in a case like this, because this would elongate even more this upper lip. So what we pretend is to move the posterior segments back, but without removing necessary volume from the total maxilla. So just bringing the posterior segments back and maintaining the same number of teeth. This, what we'll keep is the most anterior part of the upper lip, which is the vermion. It's going to be intactly in the same position, but the pressure on the upper lip will be released without altering this volume. What is going to happen is that then we are going to curve this upper lip, and this curvature, when it is exhibited, it's going to be shortening the upper lip and balancing the position. This is the most things in between extracting and non-extracting in those cases, which is that so important. And another thing that is more important, when you invite this mandible to be repositioned forward, what we are going to do is exhibiting a better scenario for the airway of the patient. We are not able to solve all the problems of the airways of every patient in the world, but we can really decompress the function of this airway beautifully with orthodontics, and this is our obligation as professionals of orthodontics. If we can boost benefit at this level, it's necessary that we step forward and we try to do the best we can for this patient. So in a case like this, when you want to exhibit a better airway, what we want to is look at the airway now when we position the mandible forward in a better scenario, we open this airway and we enhance the function of this functional part of the airway. Of course, there is an anatomical part in the upper of the upper area of the airway that is related to the transversal. But the most important part that is this, the laryngeal part of the airway, it's going to be helped very much with this reposition of the mandible. Look at the airway at the beginning of the treatment in this particular patient, and look at the end of the treatment. So this is one of the most important things. Now this patient can play beautifully tennis, and look at him. He looks so attractive, so good looking, and now he is able to put good sports. We enhance the airway of the patient. Here we can see that he looks very nice with a nice smile. Look at this patient, not 25 years old, a patient that has a class 2, but one of the most important things, patient is having TMD problems, temporomandibular disorder of pain and clicking, severe pain and clicking, and certain limitation at the opening. So a patient like this, we need to help into the reposition of the joint. When you see clicking, it's because the disc is shifted forward, the posterior ligament is elongated, the anterior ligament that is connected to the upper head of the lateral trapezius muscle is contracted, and the condyle is impinging the distal portion of the disc, that is where all the innervation, all the sensitive nerves, and the vascularization of the disc is. So is this area that is compressing is generating inflammation. Of course, this inflammation because there is good innervation, and there is a perfect scenario for inflammation and vascularization. So we need to invite this mandible to be relocated forward in a better scenario, right? She's having a massive overjet. Probably she's having more than 12 millimeters overjet and 25 years old. This is not a surgical case. This is not a surgical case. This is a case to enhance the position of the mandible. This is a case to release the condyle. This is a case to distract the condyle and to invite this mandible to be relocated forward in a better scenario. So we place the motion pipes. In this particular case, this patient was looking for an aesthetic procedure. So we placed the aesthetic motion pipe, which is a fantastic element. It's the same biomechanics, but the only difference is that it's completely clear. We position it on the canine, we position it on the molar, we position a lower molar tube or a sidekick, which is a small scoop in the molar in the lower second, and we protect the lower arch with a vacuum visual. Objective: in 4 months, accomplish class 1. But the most important thing is not the class 1 that we accomplish here. It's not the class 1. Is that this patient now is totally temporomandibular pain and clicking free. Why? Because here, look at the animation. We, in this area of inflammation, what we have done is to distract this condyle and to invite this mandible to be relocated forward in a better sagittal condition. Relocated forward in a better sagittal condition. This is what we need, no? So we invite this mandible and release. So this is very important because when we see a patient that has a class 2 malocclusion and has temporomandibular disorders, we are happy because we can help into this compression of this mandible. What is very frustrating is to see a patient that has a class 1 malocclusion and temporomandibular pain and clicking because we cannot invite this mandible to be relocated forward. So it's very important that many patients that are having pain and clicking has previously been treated by orthodontics into class 1. And this is something that is very important to brainstorm about, and something that we need to seriously brainstorm as orthodontics, right? So now we go for the new SLX clear bracket, this new innovation that we have just released on the market, and now we are so much satisfied. We place the round wire. We start with a 015 round wire. It's a 3-wire sequence now with this bracket. We place an 015 round wire. We switch into a 2020, and then we jump into a 1925. Right? This is the SLX 3D bracket clear, and the beauty of this bracket. We are not going to stop with that, but the objective is to try to be super efficient on the treatment and trying to cut treatment timings as much as we can. So normally we expect an approximate movement in between 2 to 4 months of motion, and then we switch into the brackets, and the objective is to bring the case as much as we can, as shorter as we can. So it means that every case we like to finish, if possible, now in less than 20 minutes. The objective is this one. We need to adapt the orthodontic treatment to the patient of today, the patient that is looking for efficiency. So this is what we do. We close the spaces in between the anteriors, and now it's time to retract the anteriors. So it's not difficult. But the most important thing that this patient, we retract them as we were talking before. Now we retract them like this, and we finish the case. We finish the case in a good manner. The most important thing: 10 months total treatment time. 10 months total treatment time. And this patient is having a beautiful relation between the nose, upper lip, lower lip, and chin. But the most important thing: no pain, no clicking. That this is the point. This is the pain in these patients. This is the point on these patients. 25 years old. 25 years old, so we can release this symptomatology beautifully. This is something to talk about and brainstorm about.
Which is your favorite way to open the deep bite? Reverse curve, prefab night tie, or stainless steel? And when do you start immediately after the motion treatment? This is from Dr. Anna Pacadu, Georgia.
Okay. Yes, Dr. Anna. The ideal way of decreasing the deep bite of the patient is with the motion we accomplish a class 1 platform, and this is inviting the mandible to be positioned forward. And once this mandible is positioned forward, it touches in the lingual side of the upper incisors and touches in the lingual side of the upper incisors and decreases the deep bite and the retroinclination of the incisors. Then, normally we place build-ups behind the upper incisors. Normally we place mini molds or bite rams, and which the patient can bite on the incisal edges of the patient, right?
I have to have a doctor who's very used motion for several cases. I find the use of lower molars bite turbos for adult cases actually more comfortable for some patients, especially for joint discomfort. And in class 3 cases where some of my adults experience joint discomfort after a few weeks. Have you seen this as well?
Well, it's very interesting that and I wanted to show you in the lecture that what I suggest, Celine, that we might set up the computer on. Because we have been seeing, and I wanted to show you this in the webinar, and I will try to set up again the computer on. But we have been seeing that in patients that have temporomandibular disorders of class 3, we can also help the patient. Normally, the patient of class 3 has the disc a little bit shifted back, but there are some of them. They have the disc shifted forward because the condyle also is in the deep part of the fossa. And some of them, they have temporomandibular disorders. So by contraclockwise changing the fossa plane, we are inviting to distract also the condyle from the deep part of the fossa, and this is releasing, interestingly, the temporomandibular pain and clicking on these class 3 cases. Because remember, with the motion, we are not impacting as we do, for instance, with a face mask or this. No. What we are doing is to correct the to counterclockwise change the fossa plane and to invite the condyle to be in the widest part of the joint, but not impacting this up and back, which is the important in testing.
Is it possible to treat a class 2 female patient, 53 years old, with a TMG click and a pain with the motion appliance and your protocol?
Of course, because when you have a class 2 malocclusion and there is a clicking and pain, you have an excellent opportunity to invite the mandible to be establishing a new relation with the maxilla. And so you cannot promise to the patient that you are going to solve, because we all know that the temporomandibular disorders are multifactorial, several factors that interfere. But we are able to increase or to release of the wrong positioning of the condyle in relation to the glenoid fossa, and release space for the self-correction of the position of the disc. So we find a very consistent and interesting release of temporomandibular symptomatology in those patients of class 2 malocclusion after the motion.
How young can you start a class 3 with the motion?
For what?
How young?
Normally, is the ideal, because it's the moment in which the patient is having the first upper molar erupted and the temporary canines that will be quiet during quite a long period.
Why did you say not to use vertical elastics when trying to close the open bite?
It's very important because we can have a wrong position of the tongue And if we try to close with vertical elastics while the patient is swallowing incorrectly and positioning the tongue incorrectly, there we will generate a double direction force. One of them, we with elastics trying to close the bite, and the other one will be the patient trying to open them. So back and forth is very, very inconvenient for the root of the patient, for the root of those incisors. We don't want to establish root resorptions or generate problems at this level. So we need to avoid any kind of back and forth. So the idea is to reposition the tongue and release the case with the wires to be the ones closed. You know, that the wires they close they make the movements with a very smooth and gentle amount of movement. So amount of force. So this is the objective to with this super mild amount of force and if the bite is broken means that we are going to be able to solve it.
If a patient has a missing cuspid or asymmetric cuspid position, can the motion appliance apply to the next available tooth?
Absolutely. We use very often the 6 to 4, right? And we bring the posterior segment in a correct position. Yes.
With motion class 2 appliance, how do you avoid overcorrection of the mandibular molars?
With what?
With the class 2 motion appliance, how do you avoid overcorrection of the mandibular?
No, you are not overcorrecting anything because we protect the lower arch with the vacuum inducer retainer. The vacuum inducer retainer is an excellent appliance that has to be covered the lower arch completely from 7 to 7, and the only thing that we cut is the buccal side of the molar that is having the hook for the class 2 plastics. That's all. So we protect this beautifully.
Hey doctor, is the motion appliance, does the motion come in different size or is it only one universal size?
We have different sizes for the different lengths of the position. Or the anatomy of the patient. So we have regular motions of 23, 25, 27, 29 millimeters, and the shortest also we have.
Do you continue with class 2 elastic for the second phase of the treatment?
Normally not in class 2 cases because we always look for overcorrection. What is overcorrection? We look for genuine correction, meaning that the cusp of the upper canine has to be completely in between the lower canine and the lower bicuspid, and a little bit even overcorrected. So with this, it's not necessary to go with force 2 elastics, class 2 elastics in the second moment.
How do you do arch expansion in conjunction with the motion appliance?
We cannot do arch expansion in conjunction with the motion appliance in class 2, but we can do this in class 3 malocclusion because class 3 malocclusion has the motion appliance on the lower teeth, so we can simultaneously do the sinus correction and transversal in class
3. If there's a mild rotation in the mandibular arch, is it possible to start lower aligner treatment during motion class 3D plus the class 2 elastics?
In a class 2 case?
In class 2, if there's mild rotation in the mandible arch, is it possible to start lower liners treatment during class 2? Yes.
No problem.
Yeah.
You can use a vacuum retainer, or if you prefer, you can select your aligner, and once you receive your aligners, you just cut a window for the hook of the molar that is holding the elastics, and you can also start moving the teeth with liners while you put it. No problem.
How often do you adjust or place some bends the motion appliance to adapt to the molar to the rotated canine when you have pores in the way?
Yes, it's very uncommon to have the motion. The only scenarios in which we adapt the motion is when a bicuspid is too much displaced vocally, and we need to just bend a little bit in order to avoid contact with this bicuspid and go to the canine. But this is unusual. So normally we would say that we almost never bend the motion.
Do you see advantages or disadvantage of correction class 2s in mixed dentition? Do you prefer to wait until the patient is on the early treatment?
Mixed dentition, we only go for motion when we see a retruded mandible. So in mixed dentition, when we see a retruded mandible, is a beautiful scenario to completely change this direction, no? And it's extraordinarily important to be able to accomplish this beautifully in a good condition.
How long the treatment will take to correct a full unit class 2 molar relation to a class 1?
Normally, if you have a patient that is compliant and is an adolescent, in 3 months you will run out of this. But there are other ones that you are 5 months maybe. But what is the reason? Because those patients that are 5 months, probably in the first 2 months of treatment, they are not super collaborative, and then you have to detect that, right? In a patient that is an adult case, over 40 years old, 30, 40 years old, and it has a bone density that is high, possibly you can be 5, even 6 months to accomplish that. But these also you can play with that in some of those cases that are adult and are a little bit reluctant. Sometimes we duplicate elastics at night, and sometimes we even duplicate elastics day and night.
If a specific goal is to maximize repositioning of the mandible forward in a growing child, do you, for profile reason, do you use standard force 1 and force 2 protocol, or do you use lighter elastic forces to treat it longer?
Mixed dentition normally is for 8 ounces 1/4. 6 ounces 1/4 is more than it. We are not in hurry in mixed dentition, so don't worry. If you are 6, 7 months in mixed dentition, don't worry about that. Bring the case into a beautiful overcorrection, and the most important thing, accomplish a good mandibular position.
Can motion cause second molars impact on first molar on young patients?
No, it's not causing second molar. In fact, the movement that we do is very smooth, it's not aggressive. So we never see that we impact second molars. You will have a beautiful eruption of the second molars after accomplishment of it. So don't be concerned.
What about asymmetric class 2 cases, class 2 subdivision?
And asymmetric class 2 cases, what we do is correct with the normal elastic protocol in the side that is class 2, and we place the motion in the side of class 1 with night elastics to generate a beautiful rotation and a super class 2. So we normally like to place it both to generate a rotation, night rotation of the model on the side 1, looking for super class 1, and the other side we look for the correction of the class 2. So this means that we will need a different elastic protocol in one side than in the other. So we can adjust it because it's independent, one side to.
When I use Carrière class 2 from 6 to 4 to make space for the canine, do I use the same elastic protocol with the elastic, which is force 1 for the first month,
and force 4 is the distance is very short. So in those particular cases, I suggest to start with 8 ounces. This is the force.
Can you clarify when you find the tongue thrust, tongue training animation that you reference it?
Yeah, when there is you will find in Carriere class 2 open mic, malocclusion, you can find this animation, and you also can Henry Schein can download it, right? Yeah.
From the YouTube channel, the Henry Schein Orthodontics YouTube channel, you'll be able to access the video animation, and there's a special channel for the Carrière education.
Yeah.
Do you extract upper first molar to gain a free space, or just leave them as is?
What?
Do you extract upper third molar to gain?
No, it's not normally. We will never extract our third molars to accomplish a class 2 correction. Only in the case that we would extract, only in the case that the third molars it grows towards lesion. It would be the only scenario in which.
Is it a problem of the eruption of second premolars if they are fully erupted, and we use Carrière class 2 malocclusion? I'm not sure. Have you ever had a problem using class 2 appliance with compliant patient? You cannot get a class 1 molar relationship.
Yeah, sometimes you can have a patient that is reluctant to move. So what we have seen is that you will open every case of class 2 if you duplicate your elastics. You double the elastics, changing them every 8 hours. But if there is a case that is really reluctant, what we suggest is that then you go into a short one, 6 to 4, and this with double will completely open the case easily. So when you are blocked and that you're not able to move this particular segment, just switch into shorty, and this will open your case beautifully without.
After shooting class 1 with motion appliance and removing the appliance to put the brackets on, do you still use class 2 elastic at night to prevent relapse? When you transition to the motion to brackets?
No, normally it's not necessary. In class 2 malocclusion, normally it's not necessary, so we are not going to do so. So thank you very much, doctors. I promise that we are going to do again this webinar complete in a very short run. And we will go back again. So this you can have new questions on this regard, and we are going to do it probably before the end of the year. Okay. Thank you very much.